This is a video on infestations and infectious diseases of the skin. We have a lot of diseases to cover, so let's get started. Cellulitis is a bacterial skin infection that creates a red, tender plaque, often on the lower leg. You might see streaks of lymphangitis to the lymph nodes. This is a good example of cellulitis that kind of spreads through the arm, through the lymphatic system in the arm, starting from cellulitis. This can have systemic symptoms like fever and high white blood counts, tender lymph nodes, and pain in the affected areas. Risk factors for cellulitis include trauma, wounds, systemic infection, edemas, inflammatory state, and bug bites. Cellulitis is most often caused by group A strep and Staph aureus. Treatment for cellulitis is oral antibiotics, usually cephalosporins, doxycycline, SMX-TMP, clindamycin for outpatients. For inpatients, you do want to make sure you cover hospital-acquired MRSA, so you want to use vancomycin. Erysipelas is a specific kind of cellulitis. This is a more superficial, shiny, demarcated cellulitis, as you can see in that image on the left there. And you can see that it's very demarcated. The borders are very abrupt in erysipelas compared to those of normal cellulitis in this bottom right image here. Erysipelas notably affects dermal the dermal lymph nodes, usually on the face or on the legs, and it's usually caused by group A strep pyogenes specifically. So to treat that, you want to use oral antibiotics that cover group A strep and to elevate the affected area. Impetigo is another skin infection. This is a more superficial bacterial infection. It often occurs in children that are 2 to 5 years old, and it can spread among contacts. It presents with red papules that enlarge to form a golden crust. You can kind of see that golden crust on this person's face here and in this illustration, of course. It's classically described as having a honey-crusted appearance. It's usually caused by group A strep or Staph aureus. And bullous impetigo is a variant of impetigo that has flaccid bullae containing yellow fluid caused by the Staph exotoxin. Treatment for impetigo is the mupirocin ointment or oral antibiotics that cover both pathogens like cephalosporins or macrolides. Abscesses are large masses on the skin. They are usually red, warm, and tender. They can drain pus or fluid. You treat abscesses by doing INDs, incision and drain. If a patient has multiple abscesses, immunosuppression, or other cellulitis, you do want to use oral antibiotics in those patients just to ensure it doesn't spread and just to kind of cover all the abscesses at the same time. It's unpractical to do multiple INDs if there are that many lesions. It's worth knowing the definition of a furuncle, which is a small perifollicular abscess, often seen as like a boil. Also, a carbuncle is a large congregation of furuncles, several small perifollicular abscesses, and they form one large inflamed unit that can discharge pus. Both furuncles and carbuncles can occur in hairy areas that are exposed to friction, sometimes after shaving, usually caused by Staph aureus. You can treat furuncles and carbuncles with warm compressions if they're small, and if they're pretty big, you want to treat them as an abscess, that is, do an IND on them. Folliculitis is similar. It's an infection of a hair follicle. It looks like a small red pustule with pus. It's usually caused by Staph aureus, and if a person has folliculitis after being in a hot tub or being in warm water, you want to consider Pseudomonas. That's a bacteria that's often present in hot tubs. Treatment for folliculitis is to clean the affected area with soap and water multiple times daily. You want to avoid shaving that area because that could be the cause of folliculitis. You can also administer oral or topical antibiotics or drain if it's severe. Next is staphylococcal scalded skin syndrome. This is when you have a secretion of Staph aureus toxin into the bloodstream that causes systemic blisters. The skin peels away in sheets in SSSS. The wound cultures here are negative. It's important to note that it's caused by the Staph aureus toxin, not the actual bacteria. Risk factors are children under 2 years old and patients with renal disease. Necrotizing fasciitis is a bacterial infection that spreads to the fascia, a deep layer of connective tissue, and this can spread very quickly throughout the skin. This is an example of necrotizing fasciitis, how it starts and how it progresses to kind of spread throughout the entire skin. These are usually described as pain unproportional to the physical exam findings. So this doesn't look like it'd be all that painful, but the patient might be writhing in pain. It rapidly expands to a rash with often ill-defined plaques and characteristic purple, dark discoloration, and it spreads quickly. This is another medical surgical emergency with a high mortality rate. Treatment here is to refer to surgery immediately. They need to cut this open. They need to pull out all the bacteria, wash it all out, and administer a broad spectrum antibiotics that covers group A strep and staph. Another cutaneous manifestation of infectious disease is secondary syphilis. Secondary syphilis is the second stage or second presentation of a sexually transmitted disease. Syphilis that's caused by bacterium treponema pallidum usually presents with a diffuse rash that involves the hands and the feet, the palms of the hands and the soles of the feet. It can also have symmetrical reddish-pink, non-itchy rash on the trunk and extremities, but usually you'll see this maculopapular rash on the hands and on the feet. This often has systemic symptoms as well: malaise, fever, headache, stiff neck, myalgias, but this is very variable. Not everybody has these systemic symptoms. You can diagnose this with immunostains for T. pallidum, serologic tests for T. pallidum. A lot of times patients will remember having a syphilis chancre before, and that would have been the first presentation of syphilis. You treat syphilis with penicillin G. Pediculosis is the common lice infection. Pediculosis capitis is another name for it. It's lice infestation of the human head, caused by the louse. And this causes scalp itchiness, and it might also cause posterior cervical lymphadenopathy. Adult lice or eggs can be seen in the skin. They're usually not movable along the hair shafts. They kind of hold on to the hair shafts, and they get stuck, and you can't really pull them off. And that helps differentiate them from hair casts. Children get these more than adults, and African Americans get them less than other races due to the difference in their hair structure. There are other varieties of pediculosis. There's also a body louse. There's a pubic or crab louse. And the treatment for pediculosis is an over-the-counter 1% permethrin lotion. You can also use a topical ivermectin cream or a malathion. You can also physically remove these with a comb, and it's important to wash everything. Wash and vacuum sheets, rugs, carpets, everything that might have been infested with the lice. Scabies is another infestation. This is also known as a 7-year itch. It's a contagious skin infection caused by a mite. These commonly present as itchiness with a red pimple-like rash. Occasionally, tiny burrows can be seen in the skin. You might be able to see their little tunnels that they create in the epidermis. These burrows, as we said, are linear markings representing the linear movement of the mites under the skin. Scabies are common on finger webs, umbilicus, breasts, axilla, scrotum, penis, and in the waistline. All ages get scabies. All socioeconomic statuses also get scabies. Women get them more than men. Children get them more than adults, and they're common in group settings like dorms or retirement homes. Diagnosis for scabies is skin scraping. You could look at it under the microscope, do a mineral oil prep, and see mites, eggs, or feces under the microscope. You treat scabies similarly to lice. You use a permethrin cream that you want to apply from the neck down, the entire body from the neck down, also oral ivermectin, and wash and vacuum everything. Bedbugs are another infestation. These are human parasites that feed on human blood. They're found in bedding and sleep areas, and they're often active at night. The most common bedbug is Cymex leticularis. The saliva of bedbugs has antiplatelet agents, anticoagulant agents, and vasodilators that help them get access to your bloodstream. The host presents with edematous papules scattered all over the body, as you can see in that image here. The treatment for bedbugs is that the bites resolve in a week or two, but like the other infestations, you want to clean everything, perhaps hire an exterminator. If the lesions are bothersome, you can use an anti-itch cream or a steroid for symptoms, but the symptoms should resolve in about a week or 10 days. Next, we're going to get into viruses or diseases caused by viruses, and lastly, some fungus. So we've done bacteria, we've done some infestations, and we're going to do viruses and fungi. So chickenpox. Chickenpox is also known as varicella. It's caused by the varicella zoster virus, and the initial infection happens and presents as diffuse vesicles on an erythematous base. Vesicles can be in various stages of healing and extensive across the body, as you see in this upper picture here. This is chickenpox in a young child. You can diagnose chickenpox with PCR, with a Zank prep, with a culture, or with a direct fluorescent antibody. However, to differentiate chickenpox from other herpes viruses, you want to use a direct fluorescent antibody, or PCR is probably the diagnosis of choice. Zank prep cannot differentiate between chickenpox and herpes simplex, and we'll see more of that in a second. Herpes zoster is also known as shingles. It's caused by reemergence of that same virus, the VZV virus. It presents as a painful skin rash and a localized dermatomal distribution. As you can see in this bottom image here, that's one single dermatome, horizontal stripe across the body, and that's how herpes zoster presents. It reemerges from the dorsal root ganglia and affects that entire dermatome. The rash contains vesicles on an erythematous base, just like chickenpox did. The VZV only occurs once, and this is in comparison to HSV, which can recur multiple times. And we'll talk about herpes simplex more in a bit. You want to diagnose herpes zoster with PCR. You can also use a Zank prep, but those do not help you differentiate between VZV and HSV. You treat herpes zoster with acyclovir or valacyclovir to reduce the length of the episode and to kind of treat that neuralgia, that nerve pain that you get associated with herpes zoster. Next is herpes simplex. This is caused by herpes simplex virus 1 or 2, and it's a rash. It presents as a painful rash, often around the mouth or nose, or buttocks, or thigh, or genitals. HSV1 tends to prefer the mouth and the nose. HSV2 tends to prefer the lower body below the waist, but those are not hard and fast rules. Both viruses can affect both places. The rash contains vesicles and pustules on an erythematous base, like the other herpes viruses. This recurs more than once, unlike herpes zoster, and often occurs in the same place. To diagnose herpes simplex, you want to use PCR. Again, you cannot differentiate between VZV and HSV using just a Zank prep, a viral culture, or a direct fluorescent antibody. Treatment for herpes simplex is acyclovir. This can make your episodes more mild, or you can use acyclovir to prevent a recurrence of herpes simplex. Herpetic whitlow is when you get herpes on your finger, and this used to happen a lot in medical settings where people didn't use gloves and they were examining patients, examining the mouth, for instance. You would get herpes on your finger from the patient. Next is Kaposissarcoma. This is caused by human herpes virus 8. Cell of origin here is the endothelial cells, so it's a proliferation and malformation of endothelial cells. The sarcoma presents as a dark violaceous plaques or nodules on the skin and mucous membranes. Kaposissarcoma usually occurs in patients that are immunosuppressed, such as transplant recipients or patients with AIDS. You want to prevent Kaposissarcoma with antiretroviral therapy in patients that have AIDS. You can treat Kaposissarcoma by resecting the lesions if there's only a few of them. So if it's only these two, you might be able to resect both of them. But if you have systemic disease that's everywhere, it's no longer practical to resect everything, and you want to use chemotherapy. Verruca vulgaris. This is the common wart. These skin lesions present as raised exophytic papules with a rough surface. You can see how these are exophytic. They're growing outwards, and they look rough. These are common on the hands, but can grow anywhere on the body. They can spread, especially with trauma. Now, these happen equally in men and females, but they are often common in school children and young adults. These are caused by the human papillomavirus, the HPV virus, that infects the basal layer of the keratinocytes. There are subtypes of these viruses that kind of determine their morphology. So there's verruca planae, or flat warts, and these are usually pink, smaller, smoother, and actually dome-shaped, as opposed to these, which don't really look like a dome. They look like outward exophytic growths. There's also a palmar-plantar verruca, which is a thick endophytic invaginating papule. The course of warts usually resolve, but they can take 2 to 5 years. So to get rid of them on your own, you might want to use cryotherapy, salicylic acid, but this, of course, can leave hyperpigmentation or scars or blisters. But if you want to get rid of a wart, you can do it. They sometimes resolve on their own, but it might take several years. There's also genital warts, also caused by HPV, human papillomavirus. These are sessile exophytic plaques on the external genitalia, the perineum, the perianal region, and the inguinal folds. There's extensive infection in immunocompromised people, like people that have undergone organ transplants or HIV patients. HPV types 6 and 11 typically cause genital warts, and recall that 16 and 18 cause the high-grade intraepithelial neoplasia that can lead to cervical cancer. You can prevent for all these types of HPV using Gardasil, a vaccine for HPV. And the treatment for HPV is to essentially freeze the warts off, to use electricity to get the warts off. Laser, surgery, and imiquimod, which is a toll-like receptor 7 and 8 agonist, which would stimulate the immune system to take care of the warts. Now back to some fungi. Molluscum contagiosum. These are also called water warts, but they're not caused by HPV like the other ones. These are viral infections of the skin. Molluscum contagiosum is caused by the pox virus. We're going to get to the fungi in a second. Molluscum contagiosum is a viral infection of the skin and occasionally mucous membranes. These cause numerous small, flesh-colored, clear or smooth papules with central umbilication. These can be on the face, the trunk, the extremities, or it can be a sexually transmitted infection and appear on the genitals. It's caused by pox virus, a very large virus. Treatment is not required because they usually go away on their own. To reduce the spreading of these, you can consider cryotherapy to get them off. Dermatophytes, these are the fungi. There's a lot here. They're usually named according to where they infect. So tinea pedis, for instance, would be a dermatophyte that affects the foot. This is also called athlete's foot. Tinea pedis has... It grows in an area that creates moisture. That's the shoe. People usually get affected with tinea pedis in like a public gym, a public pool, or showers. Tinea pedis presents with scaling and redness. It often recurs, and there's 3 patterns. It can be interdigital, which is between the toes. It can be vesiculobulbous, which is kind of large all over and has blistering appearance. Or it can be a moccasin type, which affects the sides of the feet up to where like low-hanging socks or the moccasin shoes would touch. Tinea pedis can also involve the nails, which is called onychomycosis, and if it does involve the nails, you do want to use oral antifungals to get rid of it because you have poor access to under the nail beds with topical antifungals. You can treat tinea pedis with hygiene. You can change your socks or use foot powder to keep your feet dry. You can also use topical antifungals like imidazoles, which are fungistatic. You can use allylamines, which are fungicidal. You could use cyclopirox, which is both fungistatic and fungicidal. Now, one of the main complications with tinea pedis is that it can lead to lower leg cellulitis. The fungal infection kind of breaks the skin and creates portals of entry for the bacteria. Tinea corporis is another dermatophyte infection, this time infecting the trunk and limbs. This is an example of tinea corporis here. It's a ringworm, and it's not really caused by a worm. It's not caused by a worm at all. It just forms this ring appearance, ring-shaped lesion with a central clearing, and that's called ringworm. Tinea corporis causes itching. It affects all the ages, and it's often asymmetric. You treat it similar to tinea pedis. You can use oral antifungals, terbinafine and fluconazole in severe cases. Tinea cruris is similar, but occurring in the groin area. Tinea capitis, this is a dermatophyte that affects the scalp and the hair, as you can see in this upper image here. Tinea capitis is more common in children, African-American children specifically. 4 to 8 years old is the most common range. It spreads through contact with animals, and it presents as there's several presentations to it. It could be a black dot. It could be a carrion, which is an abscess with pus. It can be a seborrheic spot, which is an oily spot. Usually there's broken hairs in that area too. So this looks like it might just be black dot tinea capitis. And you can see there's a bald spot there too as a result of the fungal infection. Arthrospores can be seen in hair shafts on microscopy. That's one way to diagnose it. And you treat this disease with griseofulvin, terbinafine orally. Topicals do not work in the hair. Species that might cause a dermatophytic infection are trichophyton, microsporum, and epidermophyton. And these are the most common species that cause fungal infections, and they're all kind of caused by the same species. You can diagnose these dermatophytic infections with the KOH exam. This potassium hydroxide exam is essentially taking a piece of the affected area, dissolving it with KOH, which kind of dissolves the keratinocytes, and then observing under the microscope for any kind of hyphae or other indicators of dermatophytes. So again, you see septate and branching hyphae on the microscopy, and it's important to note that these septate or branching hyphae need to extend past the length of one cell, and that's to help you differentiate the actual fungus, the actual hyphae, from common fibers that might be seen in the outer layers of the skin. And these dermatophytes usually are limited to the epidermis, so they do not cause systemic infections from where you see them here. Another disease is tinea versicolor, also known as pityriasis versicolor. This is an eruption of macules and patches on the skin, and as the name implies, versicolor, they can be many colors. They can be tan, salmon, hypopigmented patches, or macules. They're usually appearing on the trunk, as you see in this image at the bottom. They're not visibly scaly, but if you can feel them, you would feel that they are a little rough, and you might be able to see some scale if you rub it. These are seen better in the summer with tan or pigmented skin or in darker skinned individuals. These are caused by a yeast, the Malassezia yeast, which is not actually a dermatophyte, which is a bit confusing because they're called tinea versicolor, but it's caused by a yeast, not a dermatophyte. To diagnose tinea versicolor, you can confirm that there's an actual fungus there with the KOH exam. You would see short hyphae and small round spores of Malassezia on microscopy. Treatment for tinea versicolor is anti-dandruff shampoo, azole creams, or one oral dose of an azole. Scaling stops quickly, and you clear the infection pretty quickly, but the repigmentation of the skin might take a bit longer. Lastly, we're going to talk about candidal intertrigo, which is a burning red rash. Usually occurs under large skin folds, such as the groin, the armpits, under the breasts, the buttocks, the abdominal folds, and especially happens in obese people. It can also happen between the finger and the toes. Predisposing factors are hot, humid weather, and in people who are obese with low motility, who can't move around much. You might get hot, sweaty, moist in those areas. Diagnosed with KOH exam, like the other fungal infections. Treat this with topical antifungals like polyenes, imidazole. You prevent candidal intertrigo with better hygiene, and you want to limit steroid use. One more disease that's caused by fungus is diaper candidiasis. This presents in infants with red erosions to the diaper area. You often see satellite lesions in diaper candidiasis because it's caused by candida, a fungus that can kind of spread out to other areas from the diaper area. This involves the skin folds, and it's important to note that it involves the skin folds because that helps you differentiate it from contact dermatitis or diaper dermatitis. Pathogenesis in diaper candidiasis is that the urease in the feces breaks down urea from urine to ammonia. So you're breaking down urea into ammonia. Ammonia then irritates the skin, and the candida that is present in the feces can then enter the skin. You treat diaper candidiasis with nystatin or imidazole creams or ointments. Again, you want to limit your steroid use. You don't really want to treat any kind of fungus with steroids. You want to use antifungal agents. Steroids tend to spread a fungal infection if you apply steroids to those areas. So again, to differentiate diaper candidiasis from other disorders, you want to know that candidiasis has satellite lesions. Candidiasis does not improve with barrier creams because it's not a contact dermatitis. Candidiasis involves the skin folds, whereas irritant dermatitis would spare the skin folds. And of course, KOH exam and fungal culture can reveal diaper candidiasis. This has been a video on infectious diseases and infestations involving the skin. Hope this was helpful, and thank you for listening.